Good morning, and thank you for joining us today for our fourth Community of Practice Lunch and Learn webinar. My name is Becca Newman, and I am a project coordinator at the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, OTE, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into the larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release of jail, and connect first responders and behavioral health systems to increase community-based treatment access. Today's event and those we hold in the future will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice.
Hi everyone, my name is Nicole Hamame and I am also a project coordinator at the CBHJ. Becca and I will be working together today to facilitate this event. But before we get started, I just have a couple of quick details to share about how today's webinar will flow. So we'll get started with brief presentations from two of our panelists and then have a roundtable discussion about halfway through the event. After that, we'll have two more presentations and bring everyone back together again for another roundtable discussion and an additional opportunity to get your questions answered. You have probably noticed that audio and visual capabilities for attendees have been turned off. We've done that to try to limit distractions throughout the event, but we would like you to be as engaged with the panelists as possible. So if you have any questions, please feel free to enter them into the Q&A box at any time throughout the event today. So to get us started, I'd like to introduce Dr. Andrew King, who is board certified in emergency medicine, medical toxicology, and addiction medicine. He practices emergency medicine at the Detroit Medical Center, is a clinical consultant for the Michigan Poison Control Center, and fellowship director for the Medical Toxicology Fellowship. Dr. King also works at the Tolan Park Research Center Opioid Treatment Program at Wayne State University. Dr. King performs inpatient addiction consultations at the Detroit Medical Center, and his special interest is in identifying and initiating patients in the emergency department who could benefit from medications for opioid use disorder with acute linkage to aftercare. Thanks for getting us started today, Dr. King.
Well, great to be here. Thanks for the invite. Let me pull up my presentation here and get you all set. All right, so thank you for the introduction again. Everyone knows where I'm coming from. I'm actually broadcasting from the Tolan Park Treatment Center here, where I saw both buprenorphine patients and methadone patients all morning, and they're all just, this is my favorite day of the week. I do it every Wednesday from 8 to 12, and then we do a team afterwards, and it's one of the things that I like most about all of the various jobs that I have. This is one of my favorites. I don't have any disclosures. And so, I was asked to discuss what buprenorphine is, and then, some of the concerns about misuse and abuse of buprenorphine, and talk about the evidence that currently is available. And just taking a step back, everyone needs to remember, so we're all on the same page here, that when patients are on medications for opioid use disorder, and that includes buprenorphine or methadone, or even naltrexone, they function better in society. You decrease death, you decrease opioid use. So even if they are using, it's less than what they normally would be using. You have decreased rates of infectious disease transmission like hepatitis and HIV. They have improved social functioning, And then in fact, they decrease associated healthcare costs. So they're less likely to access, emergency care, just in general, because a lot of what I did today was actually a lot of primary care stuff, making sure people are following up on their test results, that they're seeing some of their subspecialists for maybe painful conditions that they're dealing with, et cetera. And it's a high touch place that we have here, where we get to see patients at least weekly, but depending on what their dosing schedule is for methadone, it could be as frequently as daily. Medications for opioid use disorder do save lives, and this comes from the National Science, Engineering, and Medicine. Tells you that the FDA-approved medications are effective and they save lives. And one of the major barriers to the use of medications to treat opioid use disorder, there's a whole bunch of them, right? But some of the main ones are actually access to providers that can provide medications for OUD. And then I'm just going to quote here is that medication-based treatment is effective across all treatment settings studied to date, and withholding or failing to have available medication for the treatment of OUD in any care or criminal justice setting is denying appropriate medical treatment addressing the opioid crisis. And, there are behavioral therapies, and I work with a lot of, some of the greatest people here are behavioral therapists, our counselors, et cetera. And they see the patients, just as frequently, if not more than I do. And they can really get deep into patients' lives and help them with, cognitive behavioral things, sussing out social situations, a whole bunch of stuff that's not even under my purview of what they do, but it's amazing. And you can start seeing transformation in people's lives as they start getting things back together, put back together with the help of a therapist that can keep tabs on them. But it should also be noted that, unfortunately, like some of the bigger studies don't see a whole lot of, incremental improvement per se with some of the behavioral therapies. And then there's a large effect with just medications alone. Opioid use disorder is complex, it's individualized, and there's a lot of predisposing factors to it, including genetics, early life experiences, environment, like access to whatever substance it is, childhood and developmental trauma, so adverse childhood events or ACEs, impaired coping skills, behavioral enforcement, all those kinds of things, put someone at risk for developing a substance use disorder. And then once they develop it, or leading up to the actual diagnosis, they start developing these basic neurobiological adaptations that reinforce and the ongoing susceptibility to substance use. So it really does become an actual disease process that you can see physiologically in the brain. Now, behaviors look, to maybe the lay person that they're just whatever it is. It's a behavioralism, but it's also part of the disease process too, that those are symptoms of a disease, and we actually put all those together to make the diagnosis of an opioid use disorder. So either case, I'm going to blow through a couple of these things, but one thing that I do want to point out here is that counseling requirements have been associated with reduced adherence to treatment. So if you're requiring that to happen, then sometimes it's counterproductive. And then a lack of available behavioral interventions is not sufficient justification to withhold medications. Like, I'm not going to give you methadone or buprenorphine unless you go see your counselor. That unfortunately isn't a great justification, at least from the academies of SEM. And so I'm just presenting to you what some of the academies and the big recommendations from a lot of the societies are. And so the other issue too to remember is that there's a discrepancy between patients who want medications for opioid use disorder and providers that can provide medications for opioid use disorder. And that is, unfortunately, there can be deserts across, not just this state, but across the country where there's no addiction specialists, and there's no methadone clinics for hours. And so it makes it difficult to get into some of the highly specialized opioid treatment programs, but maybe you're much closer to a family practitioner or an internist that's in a rural setting. And then you can make that. And there's even telehealth options. And so the idea is that we're trying to increase access to patients, but there are so many people out there who want it that don't have access to a specialist that can provide them the medication, that it's not fair. And then when you do actually increase access or providers that are able to give buprenorphine, not a lot of them use it a lot of times. And so less than 4% of eligible providers actually obtain an XY to prescribe buprenorphine. There's a whole bunch of reasons for that. And then the distribution is not uniform. So again, it's mostly concentrated in highly populated areas rather than the rural areas. And then even those that are X-waivered or have the ability to prescribe buprenorphine, for example, don't really hit their cap. Like once you provide or once you request your X waiver, you have a certain cap of patients that you can keep on the medication at the same time. And for the first year it's 30, and then if you want to expand it, you can go to 100. And if you're in certain settings, you can get up to like 250. But people aren't really meeting that cap. They'll do like 1 or 2 as kind of a pet project. That seems to be the actual average. And there's lots of reasons for that. It's a stigma of not wanting to have those patients come in your practice. There's a lot of regulatory requirements that they worry about, fear of increased law enforcement scrutiny and DEA scrutiny of the practice. And then, reimbursement issues, which is something that unfortunately necessary to keep a lot of practices alive. And so the expanding access to MAT or medication assisted therapy, they use that term on this slide, but MOUD is really pushed by a lot of agencies out there and supported by the medical evidence. And it's identified as a key component to meeting the demand that we talked about before with the treatment that is beneficial. So there's this gap here, not just of providers and patients, but even within providers themselves, to make sure that we're meeting the need, supply and demand. And now I want to talk about specifically about diversion is that, yes, anybody can abuse anything, and people will misuse medications like buprenorphine, for example. But we got to consider a couple of things. Is that when you actually ask patients who are quote unquote misusing or diverting buprenorphine, they're actually using it for the appropriate reason. They're using it for the reason that I would prescribe it to them, which is to abate their withdrawal symptoms, or even use buprenorphine instead of using heroin, because they'll feel kind of stable and they get some stuff done. And that's the whole point of a lot of this, is that they will maintain on the medication for indefinite periods of time if they can get it. But when they don't get it, then they run into problems. And so the vast majority of people are self-treating. They're already doing this, and it's not diversion, it's treatment, which is what I'm doing. I can't reinforce that enough. And there's quotes out there that people will get it off the street or they'll buy it. And I actually just had a patient a couple of weeks ago that had maintained himself on buprenorphine. This is not uncommon when they come to the opioid treatment program, is that they will be getting buprenorphine off the street or buying it or not coming through an appropriate provider for quite a while to keep themselves under control. And then when they can't, or when it becomes too expensive, or when they decide to actually, when they find a provider that can actually do it for them, if they're able to overcome some of the barriers to get there, then they feel much better about getting buprenorphine and maintaining within a clinic like the one that we have here. So again, those that use buprenorphine self-treat, and those that self-treat would actually, when you ask them, prefer to get it prescribed by a licensed provider at a supervised medication treatment program. So people want to do the quote unquote right thing. They're treating themselves appropriately, and they would actually prefer not, being subject to the whims of the supply, of the street supply of it, and actually get a steady supply of the medication that keeps their addiction under control. And that reminds me too, one thing that we have to differentiate too between addiction and dependence on a medication. Like people say, like, I just don't want to get addicted to buprenorphine. Well, the difference between addiction is that it causes problems. Dependence is, physiological. Minds that like this is the medication that you're on, that you have to be on to control your disease process, and then thinking about it as a disease rather than anything else is really important, is because when you're on a blood pressure medication, your blood pressure stays under control, you don't end up in the hospital. When you're on insulin or your diabetes medication, your sugar stays under control, you don't end up in the hospital. When you're on buprenorphine, your substance use disorder stays under control, and you don't get you don't end up in the hospital. So, just breaking this down again, this is the thing that people are going to be getting themselves anyway, and they want to do the right thing, and they're actually doing the right indication. Now, those that actually misuse it or will use it for euphoria, whatever, I like to compare this to, like using a real gun or a Nerf gun, right? If you are going to play Russian roulette, which one would you rather play with? Buprenorphine, being a partial agonist, has a ceiling to respiratory depression. So it's extremely difficult to overdose just on buprenorphine alone because you can continue to breathe. That, as opposed to heroin or another full opioid agonist, those are going to cause respiratory depression, and that's where the death comes from. So if you want to overdose on a medication, every day that ends in Y, please overdose on buprenorphine rather than using heroin or a full opioid agonist. That's where the death comes from. That's where the problem is. I'm not saying that buprenorphine alone, in combination with other sedative hypnotics can't cause a fatal respiratory depression. It sure can, and it might act differently in children. And we also have to, be very sensitive about it, the availability. We need to make sure that's safe, safely stored when it's around, so kids can't get into it. But if you want to give someone a medication to go nuts on, like that would be the one I would say every day of the week. So, and then death from 10,000 foot view is that the number of deaths attributed to CNS depression or from buprenorphine, like that is much lower than anything else from any of the heroin or other prescription opioids that are out there. Again, because it's that safety that's implicit to the medication itself. And so, stepping back again, that buprenorphine expansion, the benefits is associated with reduced rates of misuse and abuse. That their prior illicit exposure to buprenorphine actually increases, retention. So if they've used it illicitly or bought it off the black market or street or whatever the word is you want to use, that they're more likely to, once they get into a program, they're like, yeah, that was good, and I'm going to keep doing it for however long I need to. And then when people, there's a decline in illicit buprenorphine 3 months after outpatient treatment. So, when you're on it, you're on it. So the question is, like, what about decriminalization of buprenorphine, like taking that off of off the list of things that people can get in trouble for? And then we also have to ask the question, like, how are we still seeing patients who use drugs, like people with substance use disorders? Society still wants to repress or shame or punish or coerce them into doing things that is just a barrier for their success, right? Requiring counseling or requiring, intensive outpatient therapy or something like that in order to get a medication where that could be sufficient to keep their disease under control, to keep them alive and healthy. Like that seems, something that we need to think about. We don't want to repress or shame people for having a substance use disorder. And, and the other thing I want to say, that a lot of people with substance use disorders, they have incredibly sad lives, and they are incredibly, they have a lot of pain from a lot of different areas, and vast majority of them have like some sad stories that we have to be respectful of. And if I grew up in those circumstances, or if I had those things happen to me, I probably would end up the same way. So, not only that, I mean, we're going to get into this later, but, how much substance use drives, feeds into the criminal system. I'm not an expert on that, but, there's just like the amazing statistics out there. So that's it. So that's my question. That's my 15-minute presentation. The takeaway here is that unfortunately abstinence therapies are inferior to medication therapy. When people are treated, they do better. There's a discrepancy between access to like the demand and the actual availability of buprenorphine. When people misuse it, they're actually using it for the appropriate reasons. And then, MAT expansion in general, like as we continue to watch the opioid epidemic kill more and more people every year, and especially now that there's going to be an exacerbation by the COVID pandemic, I think this is going to be a problem that we're going to see exacerbated, and we're going to see worse deaths in the next couple of years just because of everything altogether. So thanks again for having me, and I'll stop sharing.
Thank you so much, Dr. King, for helping us learn more about the benefits of buprenorphine and just how safe this medication is for people who use it. Next, we're honored to introduce you to Washtenaw County Prosecutor Ellie Sabbat. Although he just began his first term as prosecutor earlier this year, the policy changes he has implemented have already far surpassed what you might expect from your local prosecutor's office. Throughout his career in public service, Prosecutor Sabbat has witnessed firsthand the cascading consequences of a broken criminal justice system. He ran for Washtenaw County prosecutor to ensure equitable justice for Washtenaw County residents, but he has easily become one of the most well-known prosecutors across the country. At the CBHJ, we are most excited about his recent efforts to decriminalize simple possession of buprenorphine, and we asked him here today to explain how and why that policy change came to be, and hopefully encourage some other prosecutors to follow suit. Welcome, Prosecutor Sabbat.
Thank you so much, and thank you so much for having me. So I think that a lot of what we're doing in the Washtenaw Prosecutor's Office really builds on what Dr. King just presented on. But I really want to start by taking a 30,000-foot view of how, at least in Washtenaw, we view our roles in prosecutors' offices in terms of the general criminal legal system as a whole. I am a prosecutor, although I'm not a prosecutor by trade. I started my career and have spent most of my career as a civil rights and public interest lawyer. And I do believe that there are things that need to be prosecuted. This would be a pretty miserable job if I didn't think that. But the question becomes, why are you prosecuting something? What do you hope to accomplish by doing so? And there are prosecutors across the country who sort of take the position that, look, we need to just prosecute everything that is a technical violation of the law, and we view ourselves as sort of a cog in the wheel on the assembly line to justice. In the Washtenaw County Prosecutor's Office, we don't think like that. We are only bringing charges, and the way in which we move forward with cases when we believe that our involvement will meaningfully affect public safety for the better. In some circumstances, of course, you look at your serious violent crimes. I do believe that people have demonstrated that they need to be separated from the community for a period of time, and that's what jail or prison is for. In other circumstances, maybe you're trying to get restitution for the victim and make the victim whole. And then there is, of course, the question of deterrence. If you say that we're not prosecuting any laws, does that lead to bad behavior? When you look at buprenorphine use that is unauthorized, absolutely none of those justifications for pursuing a criminal case make any sense. And that is because we know that if folks are using buprenorphine that has been diverted, if they're engaged in the unauthorized use of buprenorphine, they are not using that to get high, to commit crimes, to harm other people. Fundamentally speaking, and Dr. King just alluded to that, folks who are using buprenorphine even without a prescription are using it to treat their substance use disorder. And the alternative to using that medicine is that they may turn back to something like heroin or to fentanyl, and they could die. So what good are we doing prosecuting that? It's not a crime that harms anybody, so there's no victim involved. It's not something that demonstrates you need to be separated from the community for community safety's sake. And if we deter people from using buprenorphine, what are we doing? Fundamentally, what we are doing is we are leading them back on a path to use of substances like fentanyl and like heroin, and potentially to overdose deaths. Now, at the end of the day, I think all of our jobs, whether we sit in the criminal legal system, whether we sit in the medical community, whether we sit in any sort of place in society that deals with these issues, all of our overriding goals should be to reduce death. And in the state of Michigan, we have been hit particularly hard by the opioid epidemic. Since 1999, so over the course of about 20 years, the number of opioid deaths in Michigan have increased by more than 17 times. These are people that are losing their lives, leaving behind families and loved ones, and we owe it to the community to do everything possible to reduce those deaths. And so that's why one of the first policies that we put into place when I was elected prosecutor, we did this the second week that I was on the job, was to announce that we are no longer filing any criminal charges relating to the unauthorized use, the unauthorized possession, or the unauthorized small-scale distribution of buprenorphine. Now, the use and possession is fairly easy. The point at which you sometimes get pushback is people say, well, what about distribution? Aren't you concerned about diversion? And I will say, I am somebody that is concerned about diversion writ large. In my previous job at the city of Detroit, I led the city's suit against opioid manufacturer and wholesalers. And for those who know the history, the intentional blind eye that was turned to diversion of OxyContin and to other opioids is really what fueled this crisis. But when we're talking about buprenorphine, when we are talking about the unauthorized small-scale distribution of buprenorphine, somebody breaking off a little bit for somebody who needs it, what we are talking about fundamentally is somebody providing life-saving medication to an individual that would otherwise potentially be using fentanyl, heroin, and subject to an overdose death. Again, think back to the message that we're sending through the criminal legal system. Is that behavior that we want to deter? Do we want to deter people from providing life-saving medication to friends, to loved ones, to folks that need it? In my view, absolutely not. If we do that, quite candidly, we end up with blood on our hands. If somebody is deterred from providing that medication to another person that needs it, it could very well result in death. It could very well result in a relapse in which somebody turns back to street drugs like fentanyl and heroin. And that is not something that I am prepared to do in the Washtenaw County Prosecutor's Office. Now, we did this, and as far as I know, we are the only prosecutor's office in the state of Michigan that has adopted this policy. And we did it very publicly because we want people to know that if you choose this medication, if you are able to attain this medication, if you are doing it as virtually everybody who is using buprenorphine does, if you are doing it because it is medicine, to avoid fentanyl and heroin, to avoid going back down on the path to where you might be subject to an overdose, we want you to know we will not prosecute you. There are no criminal consequences attached from that. Feel free, whether you have a prescription or not, to make use of life-saving medication. Feel free to share life-saving medication with others who need it without the fear of prosecution. We wanted people to know because we wanted to save lives. And we also looked at data. And though we're in the fourth month now of this policy being effective in Washtenaw County, so it's too soon to tell what the long-term effects will be. We do know that other jurisdictions in the country have done this and have done this successfully and have done it in a way that saved lives. You're going to hear from Brennan later on, but in Chittenden County, Vermont, which is the largest municipality in the state of Vermont, the prosecutor and the police chief worked together, and they stopped prosecuting buprenorphine-related offenses. Not only were there no negative effects of any kind, overdose deaths fell by 50% the following year. 50% is a huge number. And if we as prosecutors, if we as law enforcement can do anything to facilitate a reduction in overdose deaths, a reduction in the epidemic of deaths that has been attached to the opioid epidemic, we have a moral responsibility to do so. We have a responsibility to the communities that elected us to do so. And I'm hopeful that more prosecutors' offices will follow not just our lead, but the lead of prosecutors in places like Vermont, Sarah Fair, George, and adopt these policies that will save lives and will ultimately better serve their communities.
Thank you so much, Prosecutor Sabbat. We are so glad that you were able to join us today to share about the innovative policy changes in Washtenaw that, above all, are saving lives and preventing overdose in our communities. We're about at the halfway point in our event today, so now would be a great time to submit your questions to the Q&A box. If you haven't already done so, we do see a few questions coming in already, which is great. At this time, I'd like to introduce our fearless leader of the opioid treatment ecosystem work at the center, Matt Costello. He will be facilitating our roundtable discussions today.
Thank you, Nicole. I appreciate that. And thank you to our presenters so far. It is really great information. I have a question here for Dr. King that I'm going to try and create into one, synthesize a couple of different questions. But again, the issue about behavioral health services for the individual involved in OUD or MOUD services, the funding sources often require, or state often requires when they do their audits, that they show that these services are occurring. How do we balance that need for providing the behavioral health services as appropriate and still meeting the funding or state guidelines for those provisions of services? I know you talked about this a little bit in your earlier in your presentation, but any thoughts about some of that?
Yeah, I don't want to undercut the value of counseling. Absolutely not, because I think it provides an insane amount of benefit to patients, right? But again, good counselors and counseling can be hard to come by depending on where you are. And using that as a quid pro quo for medication is not necessarily right for a lot of patients. Like some people who work 80 hours a week may not be able to have the time to get into a counselor, but they can very much get themselves under better control if they're on a medication alone. And so, every patient is different, and, patient-centered and tailored therapy is the best thing, and making a blanket rule like that without allowing for exceptions seems a little rigid to me, because there's not a lot of people. I mean, there's a certain group of people definitely that do well on medications alone, and just let them fly. I saw 3 of my patients today, they're in a really good place, and they're doing their thing, and it allows them. But if they had to do mandated counseling sessions or what have you, then it would be a real difficulty for them to maintain their current job, take care of their kids, et cetera. So, that kind of flexibility needs to be noted, I think, when you're making these kind of rules.
Do you think, just as a follow-up to that question, Doctor, that some of that is kind of a relationship building one? So an individual, if I come into your office today, just starting, the need for the behavioral health services may be higher than the 3 people you've talked about, that you may have worked with them for a more extended period of time, where that, some of those relationships have been established and trust has been determined?
Yeah, and so, I mean, there is definitely a spectrum of disease too. So some people have a lot of medical comorbidities, they have psychiatric comorbidities, they have a lot of social issues that only a counselor can really help them out with, right?
Right.
the nice thing about the addiction treatment is that there is a gamut of services. So there's like much higher level services and there are low level of services. And a lot of people, don't need that much intensive, therapy.
Right.
I think that's kind of where, hopefully I answered that question a little bit. Does that make?
Yeah, absolutely does. Thank you. For Prosecutor Sabbat, this is a question here. I'll read it as it's written so I do it correctly. I understand the desire to avoid prosecution. However, is forced coercion, for example, probation supervision, not an effective method to require treatment, particularly with referral sources and funding? If we are alleging that the use of BUP is done illegally due to the lack of resources, wouldn't our resources be beneficial? I kind of read this as, and again, I'll let you respond.
Sure. And, look, I view the criminal legal system generally as a spectrum, and there's some cases, of course, where probation's assistance and the resources that might be attached to that are beneficial. Here's the issue, at least from my end, with an over-reliance on forced coercion and probation. One is that, generally speaking, you need to plead guilty to a crime to get on probation. That can have devastating cascading collateral consequences for people, especially folks that are in recovery. One of the best things that we can do to support people in recovery and to prevent future involvement in the criminal legal system is to give folks access to jobs, to get them access to housing, to give them opportunities to pursue their education. And with a criminal record, and even with a guilty plea, a lot of those opportunities are foreclosed for a lot of people. So if you're looking at the sort of cost-benefit analysis, I totally agree. Ideally, buprenorphine would be taken as part of a supervised program, but I think the harms that come from bringing these types of charges with the best of intentions to put somebody on probation where they can get access to treatment and can get services really outweigh the benefits when you're talking about the consequences of a criminal conviction or a guilty plea, as well as, frankly, the fact that oftentimes people will fall down on probation. They may get probation violations for a variety of reasons, which can entangle them further in the criminal legal system. So again, I mean, I think you have to look at the cost-benefit analysis, as well as if you're looking at whatever deterrent effect our office's policies have. People don't want to be on probation. People don't want to be involved in the court. People don't want to plead guilty. And I really do not want to do anything that is going to cause somebody to think twice about taking life-saving medication when it's available to them, or potentially providing that life-saving medication to others. Now, again, I'll just close by saying this. I think probation, I think supervision has its place in some cases. I just don't view the unauthorized use, possession, or small-scale distribution of buprenorphine as being one of them.
Very good. Just kind of a follow-up to that, sir, is the idea, the other members of the law enforcement community that you're a part of, has there, I'm thinking both at the police level on the street, as well as you mentioned probation or parole, how do we educate them on this same kind of viewpoint that you have in terms of what we're doing to our own citizens here? Is there any pushback that you've received that way, or?
No, actually, and part of this is because of how we went about crafting our policy in the Washtenaw County Prosecutor's Office. So I won my primary election in August, and it's Washtenaw County. And if you know Washtenaw County, you know that a Republican doesn't stand much of a chance there, and indeed, no Republican filed against me. So I knew I was going to be prosecutor in August, and we used that time to craft these sort of policies that we've been putting into place. But we did it in partnership and with the advice of folks that come from a variety of perspectives in the criminal legal system and outside the criminal legal system. So, for example, example, we had a substance use working group, and that had folks that were represented, both, professionals that are in the medical space, program managers for recovery programs, again, doctors, nurses, health department analysts, but also crucially, we had law enforcement around the table there. We had the deputy chief of police at one of our local police jurisdictions who was there. We had former judges who were there. We had representation from the sheriff's office there. And so we went through this policy and we discussed it together, and we took feedback, and folks actually had conversations. And with this one in particular, I have to say, really nobody had an issue with it. Law enforcement understood the reason that we were doing this. This is not a top priority for them either. I mean, of course, they'll make the arrest, but frankly, I think they just as soon not, if they know that it's not going to be prosecuted. And bringing folks together like that and having these conversations, so folks that have clients that are using buprenorphine, or who see people on street outreach teams who can use this life-saving medication, having those conversations between those folks and law enforcement, I think was just critical. And so the rollout of this policy has been very smooth, and with law enforcement, we haven't gotten any pushback on this policy at all.
Thank you, sir. To keep us true to time here, and there's additional questions pending. The center will address those and answer them and get them back out to all the attendees here to move forward. But we want to stay true to time here. So I'm going to transition back over to the CPH team to introduce our next segment of this Lunch and Learn. Thank you.
Thank you so much for facilitating such a great discussion, Matt, and a special thanks to our first two panelists for sharing such great information. I'm sure we all really loved listening to you. It's great information. Next, I'd like to introduce Brennan Del Pozo, who is a postdoctoral research fellow in substance use, drug policy, and public health at the Miriam Hospital and at the Warren Alpert Medical School of Brown University. Prior to his time spent in research, Brandon spent 23 years as a police officer, 19 of which were in the New York City Police Department, where he commanded 2 patrol precincts, and he also spent 4 years as the chief of police in Burlington, Vermont. He led Burlington's public health response to the opioid crisis, resulting in drug policy reform and innovations in treatment and recovery that were associated with a 50% reduction in overdose deaths. We are so grateful that Brandon is here today to discuss recent research that supports removing legal and regulatory barriers to this life-saving medication. Thank you so much for being here, Brandon.
Hey, thank you, Becca. I'm hoping everybody can hear me. If you can't, somebody needs to start their camera and let me know. Otherwise, I'll just be talking. Could you please go to the next slide? Great. Thank you. And so I see that there's 135 people here today, about 120 are guests, apart from staff at the center. I see some folks I know. So if you're still out there, hey, Justin and Basha, a bunch of other folks. So in 2018, Sarah George and I, the county prosecutor, were sparring over whether we should have safe injection sites or overdose prevention sites. I recognize that they do save lives, but I felt that examples around the country show that it was a very, very, very long road to get anything like that in Vermont. They've been struggling to get one in Philadelphia for years and still haven't gotten one. Seattle saw its aspirations shut down. So one of the things I said to Sarah is, if we want to start saving lives today, doing what's within our power, doing something that doesn't require legislative approval, we can immediately decriminalize diverted buprenorphine in our jurisdiction. And we both saw it as a light bulb went on. It was off to the races. Soon after that, Lawrence Krasner, the prosecutor in Philadelphia, did so. And now we have, folks, pioneers like Eli Sabbat, also, I believe, the prosecutor in Honolulu, who's done it. And I think it's in considering the acute overdose crisis that we're facing these days, it's one of the things that we can do to renorm and prioritize medications for opioid use disorder that save lives and show that our priorities are about saving lives rather than about merely enforcing the law. Next slide, please. So Just very quickly to give you a background on my approach to policing and by default prosecution, no matter what we do, we should be guided by the underlying reasons for doing it. So prosecutors don't prosecute for conviction's sake. Police don't make arrests for an arrest's sake, and we don't enforce statutes for statute's sake. There has to be underlying goals. And I think when it comes to the opioid crisis, the underlying goal should be public health, and we should be guided by a public health ethic. And I argue recently in this article that even if we were to decriminalize all medications and drugs, not just buprenorphine, there would still be addiction-related behaviors that the police and prosecutors would be called to respond to. And it's the most important thing is not simply pointing to statutes, simply pointing to statistics, but actually showing that what we're doing is solving an important health-related problem. So if you can go to the next slide, please. There's another article briefly that has a chart that points that out, that we, this is an open access article. I think the slides will be distributed. So next slide, please. Objective is spelled wrong. I missed the copy editing, my bad. But if you look at measures, right, in policing, we want the true endpoints of what we're doing, not the surrogate endpoints. Again, when you see detectives saying, we seized 5 kilos, or we took 20 guns off the street, or you see prosecutors saying we've got an unprecedented number of convictions, you're talking about surrogate endpoints, right? So we want to identify the true endpoints of public service. This will hold us accountable for achieving our stated goals, because everybody running, even if they're running for office unopposed, someone says, I'm doing this to improve lives, I'm doing this to protect people, I'm doing this to protect my community, right? That's the true endpoint, the surrogate endpoint of the metrics. Buprenorphine arrests, just in my mind, achieve surrogate endpoints and metrics that don't achieve the true ones. And it also holds us accountable for the iatrogenic consequences of our work, right? If you're a doctor giving somebody chemotherapy, chemotherapy may well save their life from cancer, but it could also weaken them, make them lose their hair. You could be a doctor who gives somebody a life-saving surgery, taking out a ruptured appendix, doing a heart transplant. But if you cause an infection, that's an iatrogenic consequence of your work. And that's why doctors have to be extremely mindful of iatrogenesis. Arrest and prosecution do achieve goals. They help secure communities, but they also have collateral harms that we've been called upon now more than ever to measure. And in deciding to decriminalize buprenorphine, we're saying, what do you gain by making an arrest for it? And then what harms does that arrest cause? I think Dr. King and Prosecutor Sabbat have done an excellent job of showing some of the collateral consequences. Next slide, please. I participated in authoring 10 standards of care for policing the opioid crisis. It was in conjunction with Mike Botticelli, the former drug czar, Gil Kurlikowski, the former drug czar, Johns Hopkins Bloomberg School of Public Health, as well as several other chiefs of police and the Manhattan County prosecutor. And our number one focus, we did things like support of syringe service programs, equipping cops with naloxone, educating cops on stigma. Those were all other standards of care in and around policing, including medication-assisted treatment access in prison. But the number one focus for police as emergency responders, for police officers in their unique role, is focusing on overdose deaths. Police as primarily protectors of life and emergency interventionists, we said the first standard of care is to focus on overdose deaths. So next slide, please. What does that mean in practice? Well, when it comes to the overdose crisis, if the French are any indication, and I know people are loath to look at France and say, well, if France does it, that's a reason not to do it. France took a very liberalized approach to the distribution of buprenorphine. They have nothing like our X waiver, nothing like our training requirements. Any general practitioner in France could prescribe buprenorphine. That was a change they made in the midst of a terrible overdose crisis. And that change made 10 times as many addicted patients receive medication-assisted treatment. And within 4 years, France cut its fatal opioid overdoses by 79%. So just having a very quote unquote liberalized regime where it's very, very easy to get buprenorphine, where any doctor can give it out, where you're not concerned about diversion, in France in the 90s, cut fatal overdoses by 79% in 4 years. I said, listen, why do I have to police my way out of this when the doctors can doctor their way out of it? Next slide, please. Because doctors aren't able to doctor their way out of it because we have an acute shortage. This is another article out of Vice that just remarks that every dose of buprenorphine is several doses of heroin not being handed out. But next slide, please. When we look at the state of buprenorphine treatment in America, it is nothing like it was in France. Diversion continues while treatment remains accessible. Jody Rich and Tracy Green are doctors and researchers who are my mentors. Jen Carroll is a researcher who had my postdoc before me. This is an article that just shows qualitatively that there is an acute shortage at the doctor level of this treatment, and that when people seek it, as other folks have said here, they seek it to save their life, to self-medicate, or to engage in what they see as a form of life-saving treatment, regardless of whether it comports with a very rigid medicalized definition of treatment. Next slide, please. So there is some evidence coming out, and I know you've seen a lot of studies. This is yet another one that shows that unprescribed buprenorphine, illicitly obtained buprenorphine, is in fact associated with a lower risk of overdose. And I think we've hammered that point home a bunch. I won't dwell on it. Next slide, please. Methadone is a much more potent form of medication for opioid use disorder. It's much more tightly regulated. A large study done in England and Wales just reinforces the fact that buprenorphine is 1/6, by the crudest measures, 1/6 as lethal as methadone. In fact, it's a fraction as dangerous as methadone. And you've heard a lot of reasons about its ceiling effect and its medicinal and withdrawal remediating properties to show that it is not a dangerous medication to take even illicitly. Go ahead, next slide, please. So this is my colleague, Rachel Whiteman at Brown in the Merriam Hospital. She did a postmortem toxicology where she looked at 534 opioid-involved overdose deaths over the course of 3 years in Rhode Island. And her findings are on the next slide, please. And they show that out of those 534 cases, buprenorphine was only present in people who died of an overdose 29 times. So that's something that I can't overstress, is that over 3 years in Rhode Island, 534 fatal overdoses, 29 times. That's just opioid overdoses. We're not looking at non-opioid involved. Methamphetamine or other, because buprenorphine is an opioid. If an opioid was detected in the toxicology, in 5% of the cases, buprenorphine had anything to do with it. And in 28 of the 29 cases, and I'm just staying on this to hammer it home, in 28 of the 29 cases, the person also had a much more potent substance in their system, whether it was fentanyl, the norfentanyl. Norfentanyl is the metabolite of fentanyl, whether it was cocaine, whether it was methamphetamines, whether it was some other potent drug. So the takeaway for this is that in Rhode Island over 3 years, alone, buprenorphine played no role in fatal overdoses. Scientifically, you'll niggle with that, but policy-wise, no role. Next slide, please. Wayne State, Brad Ray has excellent access to postmortem toxicology data in Indiana. I got my hands on it thanks to his generosity. This is preliminary data. We're still doing the study, but I wanted to share it today. We were able, because of Brad Ray's repository of overdose deaths in Marion County, to look at 1,744 opioid-involved overdose deaths over 6 years from 2015 to 2020, and see the role that buprenorphine played in overdose deaths in Marion County, and not just 500 in a tiny state, but almost 2,000 in a big state over 6 years. One thing to note here before I go on is that what we noted is that Black decedents were much less likely to have buprenorphine in their system than white decedents. This just speaks to another problem, which is the belief that I think there's grounds to it, that Black Americans who are suffering from opioid use disorder have less access and less uptake of treatment medicines in general. That disparity shows up even when we're looking at their toxicologies after an overdose. Next slide, please. So in these 1,744 opioid-involved overdose deaths over 6 years in Marion County, Indiana, 2.8%, 49 had any buprenorphine in their system. 1,695, about 97%, 97.2% had no buprenorphine involved at all, right? When you look at what was involved, there was a positive association with methamphetamines. There was a strong presence of fentanyl and norfentanyl. There's also this understanding that benzodiazepines, when taken with buprenorphine, can overcome the ceiling effect and cause a fatal overdose. We did not find benzodiazepines to be any more statistically significantly present in buprenorphine overdose deaths and non-buprenorphine overdose deaths. Takeaway here, in this huge study, 6 years, almost 2,000 cases, buprenorphine is involved 2.8% of the time. Benzodiazepines did not play a significant role as distinguished from other overdose deaths. And in 98% of those 49 cases, there was something else potent on board, particularly methamphetamines, but also cocaine, fentanyl, and heroin. Next slide, please. So I love it when other people say they decriminalized buprenorphine and overdoses went down 50%, especially when non-scientists say it, because I can just nod and we can pat ourselves on the back. We did a lot of things, right? We started buprenorphine prescribing in the syringe exchange. We started buprenorphine prescribing at the emergency department. We eliminated the wait list for medication-assisted treatment. We decriminalized buprenorphine. We also got medication-assisted treatment available for every single prisoner or jail inmate in Vermont. All of that together, all at once, in the super messy, unscientific way, did cause overdose deaths in our county to go down 50%, where they went up everywhere else 20%. There's a 70-point spread between our deaths and the rest of Vermont's deaths over the course of the year where we did all of these things. You should do them all. But if you can only do one today by fiat, you could start by decriminalizing buprenorphine. Next slide, please. I know we're super sensitive on time. We're still going in the wrong direction. I think I'll end my presentation here because I apologize for taking up 10 or 11 minutes, but I know we have another speaker and I know this is there's a lot of important information to get out. So thank you for your time. Thank you for your voice, and I look forward to your questions.
Thank you so much, Brandon. That was amazing. I really appreciate it. So last but certainly not least, I'd like to welcome back Maya Doe-Simpkins, who joined us for our first harm reduction lunch and learn in December. Maya has been in the public health field for over 20 years, training on and researching HIV prevention, harm reduction, and safer drug use, and overdose prevention. She is particularly interested in the integration of public health, substance use disorder, and mental health treatment, with a focus on evidence-based practices like opioid agonist treatment, syringe access initiatives, and overdose prevention practices. Maya, we're so glad you're here to help bring us together, all of the content discussed today, and help drive home this idea that decriminalizing buprenorphine is part of a larger approach to reducing harm to both individuals and our communities. So thank you so much, Maya, for joining us today.
Thanks for that introduction, Becca. I really appreciate it. And it's really thrilling to follow these three presentations by my colleagues. I've heard of the work, and it was really just exciting to see the statistics and the personal stories. So thank you for sharing that. I'm just going to wrap this up by framing our opportunities here. There are, Brandon just ended with a slide saying, things are tough, things are not getting better, and we're losing so many of our community members, our mentors, our colleagues. Since COVID started, I have lost 12. And so things are urgent. As somebody who's been working in overdose prevention for more than 15 years, they've always felt urgent, and then every year they feel even more urgent. And so there's some opportunities we have here, and there's also some risks. So my talk is going to address the harm reduction context for buprenorphine access one way or another. I just want to point out that working with people who have substance use disorders and working with people who are people who use drugs, regardless of if they have a substance use disorder, and I think this is a caveat that's important to note when we're talking about involving the criminal legal system, is that not everybody who gets caught with an illicit substance has a substance use disorder or meets criteria for treatment for a substance use disorder. But working with people who use drugs is, by definition and by necessity, activist work. There's no way we can do public health or clinical work with folks without acknowledging that there is a lot of work to do. There's a lot of educating to do. There's a lot of agitating. There's a lot of defending. There's a lot of addressing stigma. And I'm just so inspired by the work that my colleagues who just presented are describing. And what they're really talking about is gold standard substance use disorder treatment, exactly the way we would hope prosecutors are viewing buprenorphine possession and small scale distribution, if the goal is to keep our communities safe, as well as policing in the context of people who use drugs who might be holding illicitly acquired buprenorphine. So this is the gold standard as far as I'm concerned, and you can see that in the results of the data that Brandon presented. And in reality, because this is activist work, the gold standard is not what's happening in many places. It's not what's going on in many places. So we have opportunities. And I also want to just very explicitly state that, particularly for people who use opioids, who have developed a physical tolerance, interfacing with the criminal legal system is fatal. At a population level, statistically speaking, it's a causal fatal factor for folks. And so we need to really be intentional and cautious the ways in which we decide to weave together public health and the criminal legal system and policing, and the ways in which we explicitly decline to weave together those systems. Because as it is now, it is not only a causal risk factor for fatal overdoses, it's also a causal risk factor for things like sex workers acquiring HIV and other STIs. So while I can absolutely acknowledge there's incredible work happening in the context of the criminal legal system, we just need to be really intentional and cautious. And I'm reminded of this when the person asked about using the criminal legal system as a form of encouraging people into treatment. And I would encourage us to consider the criminal legal system as a blunt instrument, and substance use disorder treatment and addiction medicine as a more finite and intricate tool to use for people who have substance use disorders. Aaliyah, would you mind switching the slide to the next one, please? Thank you. I want to frame this activist work and this change work appropriately by acknowledging that harm reduction work was started by people who use drugs, and it was launched by people who use drugs taking care of each other explicitly because the other existing systems were not looking out for people who use drugs. And I also include healthcare, behavioral healthcare, medicine, and in those systems of folks that were not meeting the needs as people saw them for people who use drugs. So this is an image of this incredible series of documentaries put out by Input, which is the International Network of People Who Use Drugs. And they have, I think, 10 different documentaries on the movement of activism among people who use drugs. This one here is on the United States. We have our friends Holly Bradford on the left, Louise Vincent in the middle, and Robert Suarez on the right. And I want to appreciate the work that they've all been doing for years and years and years on making sure we have access to naloxone, making sure we have access to syringes, making sure we have access to more evidence-based tools for to help save the lives of people who use drugs. I'm going to put when I'm not talking, because I can't click and talk at the same time. When I'm not talking, I'm going to put a link in the chat, in the Q&A box, or the chat box, that is a link to this video. And I would also encourage you to look for the national chapter of the Urban Survivors Union. I'll put a link to their website in there as well. Aaliyah, could you go to the next slide? And just as a very specific and finite example of the extent to which people who use drugs take care of each other and have developed care networks, I'm going to use this quote that was put out of a research. It was the first ever randomized control trial on naloxone access among people who are being released from incarceration. This is by Sheila Bird, and what she says is that the evidence demonstrate that, notwithstanding ex-prisoners' very high risk of overdose death soon after release, their altruism and concern for others is such that when naloxone is administered, the recipient is twice as likely to be someone other than the ex-prisoner. So these are folks who have gotten in trouble, got locked up, released from incarceration, equipped with naloxone because they themselves are at such high risk for fatal overdose, and then go into the community and take care of each other and save each other's lives. So in the context of decriminalizing buprenorphine, I would like for us to imagine the opportunities we might have if actually, let me stop there. I'm going to back up for just one quick second. I've worked in, I'm a public health researcher to some extent, but I more do harm reduction program implementation and, supporting local and federal government on, launching or buttressing public health harm reduction based programs. But I also worked a bunch at different needle exchanges, and there is an amazing amount of the vibe is just so different with people who participate in needle exchange programs than in any other context of working with people who use drugs that I've ever experienced, because the assumption is that people are coming to a needle exchange program to get needles, to inject drugs. And so there's really much less reason for people to be ashamed or stigmatized or not talking about what they're doing. So I had many conversations at a needle exchange program with people and participants who had buprenorphine, who had acquired it illicitly, or who were providing it illicitly to folks. When in the early days, when I was doing this work in Massachusetts, there was a really steep ramp up in buprenorphine access. And some of the stories that I heard, for example, was a woman whose partner was ineligible to get into a buprenorphine program. There just weren't enough slots, but she was pregnant. And so she sort of had higher priority. She was prescribed 32 milligrams of buprenorphine. She only needed 16. That was just enough for her and her partner to be taking the buprenorphine. This is a perfect example of what other folks have mentioned about using buprenorphine sort of exactly the way it should be. I mean, this is exactly what we would hope, is that a couple who are on the verge of having a kid both work on getting their substance use disorder, their opiate use a little bit more under control with the help of buprenorphine. So that's the backup. Is I want for us to imagine what it might be like if we could have authentic conversations with participants and clients about their interaction and interfacing with buprenorphine, including illicitly acquired or non-prescribed buprenorphine. Next slide, please. Oh, this was not the slide I thought was next. Well, all right. This is where we're at. So, our opportunities here are if we want to be in conflict with the people who use drugs, who are our participants or clients or patients, community members and family members as well, or if we want to be in collaboration with them. Because make no mistake, illicitly acquired buprenorphine access and provision is going to happen one way or another. Creating a black market does, by making things illegal, does not mean that it doesn't happen. It just means it goes underground. And we can see the exact same thing with, say, syringe service programs. Syringe service programs in certain parts of Michigan until recently haven't even been legal. It doesn't mean that there's not a needle exchange program. It means that there's not a public health oriented needle exchange program. It means that people who use drugs are taking care of each other and providing syringes to each other in an unofficial underground needle exchange program. And our opportunities are to acknowledge that and appreciate the community support work that people who use drugs are already engaged in, and support and buttress syringe access services by wrapping other great services around them. And I think the other thing that we can see is the incredible potential of buprenorphine. So next slide, please. So our opportunities are conflict or collaboration. And so I want to just, jump in a little bit to, bring us back to the stages of change and when we're talking about behavior change, particularly in the context of use disorders. What we have here along the left-hand side are the stages and the stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and then intermittently the return to use. So when we think about providing care for people who have a use disorder, we want to tailor our interventions based on the stage that they're in. And so this is another reason why I think we need to be extremely cautious of hitching our use disorder treatment or addiction medicine services to the criminal legal system, is that it does not allow for this nuanced, stage-based, tailored to the stage of change that each person is in. And so one of the points I want to make with this slide is that it isn't even until we get halfway through the action stage where we can actually expect that people won't be using illicit substances. In the pre-contemplation, contemplation, preparation, and a decent part of action, it's to be expected, right? And so I hear a lot of folks who are engaged in treatment of people who have substance use disorders feeling their hands tied, like, what can I do in these earlier stages? And so, the right hand side of this table has helper tasks, and I changed it from like clinical tasks to helper tasks because in some cases, clinicians would do it in one way, but it doesn't need to be clinical. It could certainly be services provided by people who work at needle exchange programs or people who provide peer recovery coaching or support services. So the things that we need to do with folks in each of these stages, vary on the stage. So gently raising doubts and increasing the participants' perceptions of risk and problems with current behavior. Imagine what it would be like if we could have authentic conversations with people about how they're using their illicitly acquired buprenorphine, what it does for them, how it makes them how it makes them perhaps function a little bit better than using the heroin or illicitly acquired fentanyl or other opioids, and help people gently raise doubt about what's going on. And then in contemplation, helping people sort of tip the decisional balance to evoke the changes. If we could have authentic conversations with people about how they're using the illicitly acquired buprenorphine, I feel like this would give us such incredible leverage. And this is a good opportunity to reiterate that a good indicator of success in buprenorphine-based substance use disorder treatment is previous experience with illicitly acquired buprenorphine. You could make a logical case that buprenorphine being available on the illicit market is supportive of recovery. I'm not going to go through this entire thing. I just wanted us to, particularly those of us who work with people who are active drug users or in the recovery process, what it would be like to have those kind of conversations. Next slide, please. And we know that people there's lots and lots of options for recovery, and that people do things like tapering and trial moderation and sobriety sampling and abstinence from one drug and not another. Buprenorphine, particularly with its strong affinity to the opioid receptors and its sealing effect, makes this process considerably safer for people who use opioids than if it weren't available there. It's protective against fatal overdoses. Next slide, please. I think I'm going to skip this one. I think somebody else actually already discussed this. Next slide. In defense of diversion. Yeah, I think that all of these points were also beautifully and much more in-depthly addressed by the folks who preceded me. So let's go to the next slide. And I just want us to wrap up this part of this session before we jump into Q&A, is that reducing risk is normal, and it's something that people who use drugs do every single day, is reduce risk. And I think that when we not only sort of not criminalize people's possession, use, and distribution of small amounts of illicitly acquired buprenorphine, not only just sort of don't ask, don't tell, but allow that risk reduction behavior to be out in the open and to have conversations about it, we are also bolstering people's awareness of the way that they're protecting themselves and taking care of themselves, their communities, their families as well. So the steps that people take broadly are numerous, and reducing risk is really normal. And I think that it's absolutely logical for us to include illicitly acquired or distributed buprenorphine in the array of risk reducing behaviors that people who use opioids engage in. And we should not just acknowledge it, but celebrate it. And I think there's some clinical value in being able to have those in-depth conversations. So I'm going to wrap up there. I know that we have a quick timeline turnaround for to leave some time for conversations. I really appreciate your time and energy, and I'm looking forward to chatting more.
Thank you so much, Maya. As always, it's wonderful to hear you tie things together and speak. So at this time, I'd like to turn it back over to the wonderful Matt Costello to facilitate our second roundtable discussion with all of our presenters. The only presenter that won't be on still is Prosecutor Sabbat. He had to leave a little bit early for another obligation, but we do have some time to get to additional questions for our other three panelists. So if you have not already done so, please submit your questions in the Q&A box and we'll get to as many as we can. If we are unable to get to all of the questions today, we will compile a list of written responses and they will be sent out to all attendees as soon as possible.
Thank you, Becca. I appreciate it very much. And Maya, I had to chuckle at your last slide. I was looking for the face mask, right? You know, kind of, I don't know, but just a funny thing that comes on. No shirt, no shoes, no service, but don't ask me to wear a face mask.
Exactly.
Sorry, just having a little fun there. So one of the things I think this goes a little bit to what Brandon was talking about with first I have to say, because I always have to say something, I'm blown away by our presenters today. The knowledge and the passion and the information that you guys have is just, I've been in this field a long time and I'm in awe, and that's a hard place for me to get to sometimes. But Brandon, I'm going to ask the question here about what can be, I have a question here, can be done to have the results of research actually be put into action on a wider scale.
Yeah, thanks. And you know, one of the things I alluded to at the end of my presentation was that we don't need a hell of a lot more research than we have now to start saving lives right away. And so one of the things I caution researchers when they're collaborating with practitioners in these spaces is they're calling for, well, we need to design this with a randomized controlled trial, or we need to implement this in a certain way to make it easy to evaluate. Like, no, I urge you, and I'm in the research business now, that's how I'm going to put food on the table. But when it comes to the opioid crisis, like, you need to do 20 things at once and not worry about the evaluation, because the science has been around for decades now, right? So the first thing about putting research into action is stopping the research and taking action. So don't worry about studies, don't worry about randomized trials, don't worry about knowing if it's going to work. If somebody says to you, how do you know it's going to work? Say, because buprenorphine has been proven since time immemorial to reduce overdose deaths, and we're not going to reprove that in Detroit, we're not going to reprove that in Michigan or Indiana, right? So the answer I'd say is to look at what you can do that is free at this point, and then start working on the funding in sequence. So the first thing that we did was decriminalize unprescribed buprenorphine, because it was by fiat, it didn't require a legislature, and it didn't cost anything, right? There are other measures that you can do in the bigger picture now that save lives and stop the spread of disease, like decriminalizing syringe possession, right? There's low-cost measures in the scheme of things. Naloxone distribution is a low-cost intervention. And then the bigger things to work on are treatment in prison, right? And that requires usually a legislative move or a big policy move. And the other things I'd say is just to, you know, I don't want to dominate too much of the floor, so I'll just take another 30 seconds, but don't underestimate, if you are a public servant out there, if you're a prosecutor in the audience or a police officer in the audience, like the normative power that you have. The harm reductionists are trying to get buprenorphine prescribed out of the syringe exchange for years in Burlington, Vermont. I didn't make that idea up. But when I came to the community and said, it's time to prescribe buprenorphine out of the syringe exchange, they said, crap, if the cops are saying it, it's time, right? And so, like, building those bridges between physicians, prosecutors, cops, harm reductionists, like, that sends a strong, strong message. So don't underestimate, like, the last thing I'll say is we never really arrested that many people for possessing buprenorphine in Burlington, but the principle and the renorming of it and the destigmatizing of it was a power that the prosecutor and I had that was really, really important. So I know I gave a laundry list of things to do, but if you stop the research and start the implementation, do it all at once and capitalize on your power as a public figure, you could probably get things done pretty quickly.
Thank you. Yeah.
Can I just jump in there a little bit? And I could not agree with you more, Brandon, that
Thank you.
I mean, research is not what we need. We actually, this has been evidence-based for a minute, but oftentimes I found, as you know, doing activist work in the context of public health and people who use drugs, is that sometimes people ask for research as a sort of stopping the conversation measure. Well, where's the research? Oh, there's research in Vermont, but Vermont is not Michigan, or Vermont's not Indian country, or Vermont's not. So what I think that sometimes people request the research as a way to kind of divert the conversation. And so oftentimes big decisions are not made based on research. They're made based on emotions or connections or what somebody else who they really respect has an opinion about it. So I just wanted to add that to your advice.
No,
Brandon.
and
I think that's
Maya,
really
the
great.
one thing that it's why that's a little bit, so forming a committee or doing a study or getting research is a delaying tactic. You could use that to delay implementation. But the one thing that makes that kind of disingenuous is the data waiver and the present regulatory regime around methadone and buprenorphine is not based on research or evidence to begin with. If you go back and look at the history of buprenorphine, when it was introduced to the market in 2000 with the data waiver, that was a political compromise to get an orphan drug to market amid fears that it would be just another form of methadone. There was no science at all to the regulatory regime that we have now. So to say what we're doing now is costing lives and not based on science, but I'm going to demand science to get away from that is disingenuous when the individual clinical level science is clear that it saves lives.
Yeah, it is that bias kind of garbage, I think, that derails it. I was wondering too, as I hear you talk, I wonder about local health departments, right? These county-run governmental agencies, and I'm wondering how I don't know them to be a harm reduction kind of area. How is that? I'm not sure how to even phrase the question. It seems like such a natural alliance, a natural landing spot for people to utilize or access harm reduction services. Is there any connectivity that you're aware of that kind of embraces that model?
It's really complicated. I feel like there's logic and there's research and then there's reality, right?
Yeah.
And I feel like, for example, addiction medicine is probably the area of healthcare where science is most ignored in terms of the regular practice, like what happens on the ground. Some clinicians are always following gold standard behaviors, and other ones are not. And I feel like the same thing is the case with public health. I mean, harm reduction is a philosophy. It's not necessarily a set of services, but it can, the idea of harm reduction contains a set of services that are super logical public health. I mean, like the most effective HIV prevention intervention that we know of is giving people syringes. We've known this forever. So on the one hand, local health department operating syringe service programs is completely logical. And if there's not somewhere embedded in the services the philosophy of harm reduction, it might be either not super successful or not perceived as safe and authentic for people who use drugs. If you go to the same place to vaccinate your babies as you do to get your syringes, you're going to want to vaccinate your babies there and stay away from there for your syringes. So It really depends. And, the way that a local health department that is, sort of on the border there could do is to locate the natural carers in their communities who are people who use drugs, who are already providing syringes to their drug using community, and capitalize on those networks and really support and appreciate and empower them to be doing it in a community. So,
yeah. Thank you. Another question here is, and again, this is near to my heart too, is what recommendations do you suggest to engage a direct link between psychiatric crisis services and substance use care? I'll open that up. Maybe Dr. King, start with you on that. If you have it, certainly that has to be a possible common thread in your practice.
Yeah, it's interesting that there are psychiatrists, there's addiction psychiatrists, there's addiction medicine physicians, and there are some psychiatrists that don't want to or don't specialize in substance use. it's part of their general training. But, you know, we end up a lot of times in medicine, like being very siloed in our specialties, and we don't make that connection. And it's surprising a lot of times, like how often all you have to do is just open the conversation, and people don't really realize that they're even standing side by side with each other. And so it's trying to find and continuously make that connection. And there's a bit of upkeep when you're making that connection too, about those connections. And then, you know, going back to what I think Maya said is that there is well, actually, I'm not going to say that out loud, but
Well, go ahead.
I'm sorry.
Well, I appreciate that, Doctor. And again, we try to at the center try to be very attentive to time here, and we're 2 minutes before the close. For those who didn't get a chance to have their question answered, as Becca said, we'll send out answers. I personally, again, want to thank our presenters today. That it was just again, I'm just blown away by your work and your commitment. It just radiates from each of you. So, Becca, I'll turn it back over to you for the closing, and we'll move on.
I am actually going to jump in for the closing.
Oh, well.
But thanks, Matt. Thank you so much to all of our panelists today. And I believe I saw 135 people in the audience. That is fantastic. We're so glad that you were able to join us, and hope that you found this information thought-provoking and hopefully something that you can act on in your own community.